So you'd start off with the neurological examination, having done and having noted down the physical features, the pupillary reflexes, as well as the skin of the patient in detail. You would find out certain factors that are contributing towards this vegetative condition in the individual. The neurological examination starts off with observing the patient, just inspecting the patient in detail, the generalized posture of the individual, the spontaneous movements, and the respiratory rate are noted down when you're inspecting the patient in detail. Then you're going to calculate the GCS, which is the Glasgow Coma scale. And it's basically a scale till 15, 0 to 15. And that is basically helping you distinguish the milder, the moderate, and the severe cases of unresponsiveness. So having a patient being diagnosed with coma or the condition is the vegetative responsiveness in the individual, you should be well versed with this Glasgow Coma scale and how to calculate this in a particular patient who is unconscious. So we'd be going through the details of that. The pupil and eye examination is something that you would be doing in detail. The pupillary reflexes, the eye movements are noted down, and you're also going to distinguish between the comatose individual and the locked-in syndrome in the individuals. The retinal examination is done in detail, focusing on papilledema, focusing on any features of subarachnoid hemorrhages, and basically an increased intracranial pressure as a result. So the history is, as I was already defining the fact that history is going to reveal a lot of factors, as we even saw in our case study that the patient suffered from a traumatic history resulting in brain edema, resulting in subdural hemorrhage, and all of this can basically resultantly increase or elevate the intracranial pressure. So you're going to look for the features and you're going to concomitantly collaborate all of these features in the history with the physical and the neurological examination in detail. Plantar reflexes are basically done when you're going to distinguish between the decerebrate injuries in the individual. One of the reflexes is noting down if the Babinski sign is present or not. So you perform this test, and that is basically a positive Babinski sign is going to reveal the fact that the patient is suffering from an upper motor neuron lesion. Other reflexes, you're going to look for the corneal reflex, checking for the third cranial nerve, Dole's eye, Gagg's reflex, and again, you're going to basically focusing on the cranial nerve examination or the cranial nerve functioning in the individual. Glasgow Coma scale is calculated in a particular way. It has three major components: eye response, verbal response, and motor response. Eye response has a total of 4 points, one for no eye opening. Eye opens to pain, you give the patient 2 points. Eye opens to verbal command, speech, shout, it basically gives 3 points to the patient. And eye opens spontaneously, it gives 4 points, that is a full score to the patient. If the patient is oriented, it's a score of 5, confused conversation, but able to answer questions, then you give 4 points to the patient. Inappropriate responses or words are disassembled, then you give a score of 3. Incomprehensible sounds of speech accounts for 2 points, no verbal response, that makes a score of 1. Motor response has 6 points in total. If the patient obeys commands, you give a total of 6. Purposeful movements to painful stimuli, the total is 5. Withdraws from pain, the total is 4. Abnormal flexion, decorticate posture, the total is 3. Extensor response, decerebrate posture, it gives you a total, it gives the patient a total of 2 points. And if there is no motor response, even to painful stimuli, then the total score for this motor component would be 1. So this is how you calculate the Glasgow Coma scale, and it can be a total of 15 points for the patient. Usually a patient who lies in the category of 0 to 3 points is suffering from severe unconsciousness or some sort of a severe condition that is basically affecting the responsiveness. The level of arousal, the normal consciousness, and if there is a higher Glasgow Coma scale, the patient is easily aroused. Then we have a comatose patient, a patient who is in sleep or anesthesia. He would have a low GCS, and the arousal or the awareness would also be decreased for these individuals. Patients who are in a vegetative state, they are aroused but they're not aware of their surroundings. The cortical regions are usually affected for the patients who are suffering from the vegetative conditions. So you'd be looking for the levels of arousal in the individual that are basically indicative of the underlying pathology as well. We're going to check for the brainstem reflexes as well. The corneal brain reflexes, the nuclei for this particular reflex are found in the pons region, and we have the cranial nerve nuclei for the 5th and the 7th cranial nerves that are lying in the ventral portions of the pons. And then we are also going to look for the reflex conjugate eye movements. The nuclei or the cranial nerves that are involved are the 6th and the 8th cranial nerve. The nuclei again are lying in the upper brainstem and the lower pons area. The respiratory movements are also looked for, and the neurons are usually found in the medulla oblongata. The lower portions of the medulla are involved and the neurons are lying over there, and you look or you check for the respiratory movements to evaluate the functionality of the cranial nerves or the functionality of these regions.